Welcome back, everybody. Hope you made it into this second session for today. Really excited to welcome this next session and the next moderator. So Mitchell Running is the Population Health and Performance Manager for the Wisconsin Primary Healthcare Association. Mitchell provides support in the areas of value-based care, data and analytics, and clinical quality improvement to the state's 17 federally qualified health centers and Wisconsin Health Plus, which is a network of clinically integrated health centers. Most recently, Mitchell worked as a legislative liaison for the La Follette School of Public Affairs, where he connected legislators with policy experts on the UW-Madison campus. Prior to that role, he worked in multiple sections at the Wisconsin Department of Health Services, including the eligibility, enrollment, and Medicaid managed care teams. Mitchell holds master's degrees from the UW-Madison School of Medicine and Public Health and La Follette School of Public Affairs. He was named the Stephen F. Brenton Health Policy Scholar in 2017 and was nominated to the Delta Omega Honorary Society of Public Health. I'm so pleased to have Mitchell here moderating this next section, and he will then introduce our wonderful speakers. And so I'm excited to hand it over to Mitch.
I am very grateful for that introduction, and I apologize. I'm just getting some data together here. So before moving on and introducing our speakers, I know you just came from a morning session discussing where the state discussed kind of Medicaid unwinding and where we're going. But we thought for those of you that were not able to attend that, it would be worth doing a really high level overview of kind of where we've been and where we're going with Medicaid redetermination, because we know that's obviously the big topic on everyone's mind. So I've just got a couple slides for you here. All the data that I'm going to be showing you is directly from the Wisconsin DHS website. They have Medicaid renewal data up there, and so if you haven't checked that out already, I would definitely encourage you to, and they will continue to update that as more data becomes available. And just one quick note, we only have data through July of 2023 so far, so we're still waiting for that August and September data to roll in. But again, go check that out. DHS will be updating that regularly. So just kind of high level, where have we been with Medicaid enrollment? So pre-pandemic, back in March of 2019, we had about 1.2 million Medicaid beneficiaries enrolled. As you will all remember, the public health emergency was declared in January of 2020. And shortly after that, the Family First Coronavirus Response Act was enacted, which froze the Medicaid disenrollments. And that happened in March of 2020. And it's at that point that we start to see that steady rise in overall total Medicaid enrollment, which reached its peak in May of this year at around 1.7 million enrollees. Obviously, at that point, redetermination started happening again. And so that brings us to almost present day of July 2023, where we've got about 1.6 million Medicaid enrollees. So over those few months, a loss of about 100,000 members, about 100,000 members losing that Medicaid coverage. And so obviously, sorry, last thing, obviously the concern is that, as the unwinding plays out, I think everybody in this room, as well as our panelists, is keeping an eye on that to see, do we fall significantly below that March 2019 enrollment level due to beneficiaries unnecessarily losing coverage. Last slide for you. Just a little bit deeper dive to kind of see what we're looking at here. This is also data that I pulled from the state website, and it's the more detailed breakouts are only available for June and July. So again, we'll get more data as it comes through, but we're really just looking at a snapshot of those 2 months here. But it gives us a little bit of an idea of kind of where a lot of the renewals are coming from, and you can see, understandably, that Badger Care Plus. The Badger Care Plus program is where a lot of those renewals are coming from. So over those 2 months, there were roughly 194,000 renewals due. Of the renewals that were actually completed, so some are still pending and haven't been completed, but of those that have been completed, we can see that 90,000, roughly 90,000 folks retained coverage, and roughly 93,000 lost coverage. So we're seeing a little over half of those renewals resulting in a loss of coverage for the Medicaid program. And then finally, on this far right, the other thing I wanted to highlight, if we dive deeper into that big bucket of Badger Care Plus renewals, you can really see that it's the adults without dependents and children that are making up the majority of those renewals. So so that's just a really high level overview of kind of the most recent data that's available and kind of where we're at right now. So I will stop sharing um, and move on to introduce our panel today. And we've got a great panel of speakers with us to talk about the payer and provider perspective on health insurance coverage in Wisconsin. So first, I'm going to introduce Joanne Alig from the Wisconsin Hospital Association. Joanne joined WHA in December of 2010 and currently serves as the Senior Vice President of Policy. Her primary areas of responsibility include Medicaid and commercial insurance, the health insurance exchange and enrollment, national healthcare reform, value initiatives, and workers' compensation. It's a large portfolio, Joanne. So Joanne brings a unique perspective to healthcare issues with her history and experience working for the state, payers, and providers. She has prior work experience with the Wisconsin Legislative Fiscal Bureau, the Wisconsin Department of Health Services in the Medicaid program, the Wisconsin Association of Health Plans, and Deloitte Consulting. So thank you for being here, Joanne. Next, I'd like to introduce Kelsey Avery. Kelsey is the Director of Policy and Operations at the Wisconsin Association of Health Plans, which is the voice of 12 community-based health plans that provide insurance coverage across the state. In this role, she specializes in healthcare coverage issues with a strong emphasis on Medicaid and the individual market. Before moving to Wisconsin and joining the Wisconsin Association of Health Plans in 2017, Kelsey spent 3 years working in Washington, D.C. at the U.S. Department of Health and Human Services, as well as on Capitol Hill. So Kelsey, thank you for joining us. And last, we have Kevin Moore. Kevin serves as the Medicaid Committee Chair for the Alliance of Health Insurers, as well as the CEO for the Community Plan of Wisconsin in the Medicaid and Dual Special Needs Plan line of business for United Healthcare. Kevin has an extensive background in Medicaid, social determinants of health, public policy, and strategic solutions, and has a long history with state-based and government sector programs. Kevin has previously served as Medicaid Director for the state of Wisconsin and as the Deputy Secretary of the Wisconsin Department of Health Services. So, Kevin, thank you so much for joining us. So, for all of our attendees, thank you all for joining this session. I think we're going to have a great discussion. Just to give you a heads up on kind of the format for today, in a second here, I'm going to kick it over to Joanne, Kelsey, and Kevin to talk a little bit, give us kind of an overview of current state, what things are top of mind for them as it relates to health insurance coverage in Wisconsin and how their organizations are thinking about that. And then we're going to move right into Q&A. And so we will have a lot of time for question and answers. So please feel free to submit any and all questions that you might have in the chat, and we'll make sure to get those answered. So with that, Joanne, I'm wondering if I could kick it over to you.
Sure. Thanks, Mitch. Thanks for those introductions. Really happy to be here today and to be on this panel with Kelsey and Kevin, who I've known for a long time. So great to be with you all. And Allison, thanks for your work with Covering Wisconsin. and for putting on this wonderful enrollment conference every year. I want to say this is the 10th year since this began, and every year it's certainly a highlight for us and for all of those who attend. So thank you. I want to start just by sort of saying, although I've been at this conference before, I want to say who WHA is, with the Wisconsin Hospital Association. All of the hospitals in the state are our members, and we do a lot of work on their behalf. Our mission is really to help them fulfill their missions for providing high quality, accessible healthcare in their communities. And we are really pleased that just recently we again received an award, or we again got recognized from CMS. We have the 4th highest number of 5-star hospitals in the country, according to CMS. So we're really proud of that. And we're proud of all of the work we've done over the years to help patients access coverage. And that means helping them access care. Even before the ACA, hospitals have always had financial assistance staff, have had patient assisters who have helped patients find coverage and enroll in that coverage, because we know that helps them then access services, healthcare services, and afford the coverage that they need. We all know why that's important. And now with the Medicaid unwinding, we are again kind of stepping up to ramp up and help patients who may be looking to reapply for Medicaid, who may have recently been disenrolled, and to really try and help them make sure that they are not falling through the cracks and that they are getting the coverage that they need. 10 years ago, we really ramped up with the ACA, and we've sort of done this work before. And this time it's a little different with COVID. And a lot of our hospitals are stretched thin with resources, with workforce, but they also recognize that this is really an important endeavor for their patients. We are really thankful to the Department of Health Services, because they are providing hospitals with lists of their patients who have been in Medicaid fee-for-service, not the HMO side, but the fee-for-service side, so that hospitals can conduct outreach and try and reach out to those folks and remind them that they need to apply, and then find out if they haven't or if they've been disenrolled, what resources they might need. And hospitals are doing that. It varies across hospital depending on how many Medicaid patients they have, the resources they have available. We have one small hospital who, for example, has about 30 patients a month, and they're just calling them, just getting on the phone and calling them and finding out and reminding them to apply and reminding them to re-enroll. We have others who have teams of people who this is their whole job. And so what they're doing is a variety of outreach activities and a variety of one-on-one patient assistance. What we're hearing varies on this topic. Anecdotally, it's kind of what we expected, that there are some people who no longer have Medicaid coverage, but our hospitals know that they have maybe coverage through an employer, for example, and they know that because they're billing that other insurance, right? And there are some people who are have not reapplied. They, despite all of the messages and all of the work that everybody has been doing the last 2 years, which is really commendable, they just somehow didn't know that they were supposed to reapply. And then there are some in Milwaukee, I think, that are having a little harder time, and I think we'll probably get into that a little bit. And we know that there are some staffing challenges there, and we know that those are being worked on, and everyone's trying to address those as well. What we would look forward to is an opportunity to have more data and more information, because obviously we don't want people to become uninsured. It'd be really great. I got on the website this morning, and even the federal government website, there's They're 2 months behind. They're back in May still for the data that they have out there. And I think we need more timely data. And so I know folks are working on that. Kelsey is the lead of a data work group. And so I know that that's being worked on. But I think that's one of the great needs is to have more timely data about are people enrolling in the exchange marketplace? Do they have employer coverage? Why are they not? Why are they being disenrolled from Medicaid? All of that being said, I think that the department and the Legislative Fiscal Bureau, when they were analyzing the budget and trying to estimate how many people are going to be enrolled over the next couple of years, estimated that we would end up back at pre-pandemic levels. But as Mitch said, we have to keep on top of that and keep watching that. People being disenrolled from Medicaid isn't necessarily, a bad thing. It can be, but it's not necessarily. It just depends on, are they getting coverage elsewhere? And so I think we just need to keep on top of it and continue to do all this great work. At the same time, we know that open enrollment is coming up for the ACA and Medicare and other coverage. And so we all have a lot of work to do. I'm really hopeful in our state. I got a call from another colleague in another state who felt that she didn't know what was happening in their state. They didn't have a coalition like this. They didn't have, health plans and hospitals and all of you and Covering Wisconsin and the Milwaukee Enrollment Network and all of the folks that we have engaged in this work. And so I'm really hopeful in our state, despite some of the challenges, that we will be able to move forward and make sure that we're providing good, accessible, affordable healthcare to our residents. So with that, those are my opening comments. I'm going to turn it over to, I'm not sure if it's Kelsey or Kevin or who wants to go next.
Go ahead, Kevin.
Yeah, I think I'm up on deck. So again, I want to just echo what Joanne said. Thank you all for the opportunity. A lot of us have been together, have worked together for a long time. And I do think that might be some of the special sauce that makes Wisconsin unique compared to other states. Because when we do have issues, we don't have any problem picking up the phone and making a phone call and trying to figure out what the issue is. So again, Kevin Moore, I'm here on behalf of AHI. We have 6 Medicaid HMOs in the state that we represent. And I'll just probably say everything Joanne said, and probably the plus and would be, I think that payers, no matter where they are in the state of Wisconsin, it's an all hands on deck approach right now, primarily because we really are in a fluid situation. And Joanne hit on a couple of things. Data. We need more data. We want more data, but the data in and of itself is fluid, primarily because a member's scenario is going to be different month 1 from month 2. So again, as we look at that information, how are we ingesting that information, analyzing it, but then also finding partnerships across the board, whether that be community-based organizations or, as Joanne said, the hospitals are getting information from the state of Wisconsin, but there's an opportunity for us to collaborate better as a payer and provider to provide a seamless venture there. And we're doing that. We're actually, a lot of the hospitals are reaching out to payers individually and saying, look, can we get a list of your members? And we're saying, sure. Can you help us connect with them? Because again, the overarching goal is we want people to be covered. And we want to make sure that we're making it as seamless for the member as possible. But as we're looking about all hands on deck, we also are realizing there are policy changes, thinking about just in real time how the state has made modifications and edits so that a partial application now provides an additional 1 month worth of coverage. It's a great policy. It keeps people covered. It also means that when we think about data, when we think about outreach, we have to be pivoting in real time, which really leads to the 2 C's in my mind, which is communication and collaboration. We need to make sure, and we're very fortunate, whether it be provider, payer, CBOs, all of you on this call, and ultimately with our state partner, a willingness to understand, look, we have a question, we're hearing something, there's a concern out there that's either anecdotal, or if we're able to bring enough groups together, we realize that it might be a bigger issue than just a 1 or a 2 off issue. So if you think of all of that, the data, the policy changes, communication, collaboration, it really influences 2 things. It influences how we operate as health plans, making sure that we're getting information out in a timely manner, that we're engaging with our members, in the right way, in the right time, that we're collaborating, as I said before, with our payers or our providers and our community-based organizations. All of this is designed for one thing, is we're looking for engagement. We want members, patients, clients, I don't care what you call them, it's all the same person at the end of the day. We want them to take action. We want them to go to their income maintenance consortium. We want them to get the Access app. We want them to go online. Yes, if they're at a provider, we want them to be able to know, look, we want you to get back into the queue. Some of them won't be eligible. Totally understand that. Then let's figure out, is it an ACA product? Is it a commercial product? But on the other side, it's also recognizing that it's not just about Medicaid as well. There's other benefits in Wisconsin that when you get into that portal, they can make sure that they get covered, whether it be food share, whether it be childcare or Medicaid. All of those things are beneficial in terms of helping families live their best lives. So at the end of all of this, it's an engagement play at an epic proportions. We've never done this before. 2014 with ACA is a small microcosm of what we're doing right now. But I think what you're going to hear today, and I know that there's CBOs, community-based groups across the board, is a work towards alignment. How do we have a similar message? How do we have a similar approach? How do we not step on each other? Because at the end of the day, we need families, individuals that are in Medicaid to take action. And we already knew there were barriers before the pandemic in terms of things like data. Do we have the right phone numbers? Do we have addresses? We need to continue to fix those or work on those without all of us confusing and clouding the issue of what we need people to do. So at a very high level, that's what I'm seeing. And Kelsey, I'll flip it over to you and what did I miss?
Yeah, well, I promised I wouldn't be duplicative of either Kevin or Joanne, so I get the fun job of bringing up the rear here. So Kelsey Avery with the Wisconsin Association of Health Plans. As Mitch said at the beginning, we represent 12 community-based health plans, provide coverage across the state. Many of our members provide coverage both in Medicaid and the individual market. They also serve employers, the state employee health plan, Medicare program, et cetera. There's a few themes that were coming through in Joanne and Kevin's comments, and one that I'd really like to pull out and kind of highlight as an opening comment is, while redeterminations have resumed, I don't think any of us would characterize this effort as just restarting old processes. This whole process has required a fresh look collectively at process, policy, operations, communications, a wholesale reevaluation of the work that we do to get people through a renewal process. And so you'll hear about a lot of that great work that folks across the state are doing. Obviously, a lot of you are engaged in that work directly as well. And then the data piece, that Joanne and Kevin were both talking about, I think has been really instructive. And one of my biggest takeaways thus far has been that an understanding of data cannot be divorced from an understanding of policy and administrative procedures. If you don't have a good handle on the what of what is happening, all the data in the world can't make a story for you. And so that to me, I think has been a really critical learning piece in these first few months. To Kevin's point, we're learning, we're tweaking along the way. Those have been necessary and important, and we are going to learn and tweak throughout the remaining months of this process. And it means that from month to month, the story is not necessarily 100% comparable. And so we're very much learning in real time and trying to adjust. And that just has been a really big theme, I think, especially for the HMOs who are contracted vendors with the state responsible for doing direct enrollee outreach.
Great. Thank you all for those perspectives and those introductory comments. I'm very excited to dive into that. We covered a lot already. So we are going to move into Q&A. So again, feel free to start putting questions in that chat bot. Before we get there, I believe we have a poll question for you that we wanted to pull up. Allison, is that correct?
That is correct. And the tech crew will pull that up for you in just a minute. People should be able to, in just a moment, be able to see that on the side of their screen. And it populates as people enter their responses.
All right, there we go. I believe you should be seeing it now. So the poll question, do you know where to go or do you know who to ask for information about what's included in Marketplace health plans available in your area? And Allison, please just flag for me when you think we can move on and we've got enough responses.
I think we got a good handful of responses here, so I think you can move forward.
All right, so moving into Q&A, see we have one question coming in already, but I want to kick us off with a question before that one, because I think all of you in your opening statements talked a little bit about working with partners, really kind of an all hands on deck scenario, and I was just wondering if you would mind going into a little bit more detail what work you're doing with the state and what work you're doing with each other as well, because I know that's a big piece of this as well. So Joanne, wondering if I could start with you again.
Yeah, sure. Thanks. So as I mentioned, we've been engaged at WHA level and some of our members too with the state for the last couple of years as they've been sort of having their regular monthly calls and meetings and really trying to make sure that we understand and are supporting the messages that the state is putting out. We worked with them to, again, make sure that our members could have sort of lists of their patients. This is Medicaid fee-for-service again. So lists of their patients that they could access. So these patients are patients of theirs that have come to their facility in the last 6 months to a year. And so we know that they come to that hospital or that health system. We know that the financial counselors, that the patient assisters will have interaction with them. And if they can sort of reach out proactively to those members and those patients, and they get those lists updated on a monthly basis. And so they can go out and access and know who is up for renewal on a month-to-month basis, and can sort of really try and do some outreach and sort of work with those patients to help engage them to make sure they're completing their renewals. And to, if not, or if the patient has been determined not eligible, how can they help them find other coverage options, whether it's through the exchange marketplace, whether it's through their employer, whether it's Medicare. Some patients might need to access Medicare at this point. So really trying to sort of work one-on-one with those patients.
Thank you, Kelsey, Kevin. Any thoughts? Any responses?
Lots of thoughts. So Kevin, I mean, you'd be aware, obviously, that's not an exaggeration to say that for the Medicaid health plans, we've been working towards this moment for years with the state. Of course, we've been working with other partners, including providers along the way, but discussions with the state about this process, when it would start, how it would go, began as far back as 2021. And we've been, again, working towards this moment for quite a while. When it comes to partner collaborations, I'd say, and I'm not just saying this because I'm at Allison's enrollment conference, I think as an association, our relationship with Covering Wisconsin hasn't been stronger than it is in this moment. I've really appreciated the opportunities and collaboration that's provided across a variety of venues. And when it comes to provider collaboration, I mean, that's a core component for our members as they think about the redetermination process for their enrollees. For folks who are in our membership who are part of integrated delivery network, there's ample and easy opportunities for them to work with their contracted providers, up to and including sometimes physical signage or shared workflows, related to either helping people through the Medicaid renewal process, or in the event that someone is no longer eligible for Medicaid, ensuring that they have a soft place to land. They may already have that place, but if they don't, helping them get to that point. Mitch, you'd well know that the collaborations with FQHCs have been important to the Medicaid health plans. Obviously, FQHCs are a really big component of that provider safety net for these folks. And so the kind of back end collaboration for HMOs to be sharing data with FQHCs about who's coming up for renewal is really a really important touch point. And so those are just a few examples, and I'm sure we'll dive a lot deeper and provide more specifics as the time goes on, but that's where I'll start.
Yeah, no, and I can add to that. Having been involved in those discussions in my role with the Wisconsin Primary Healthcare Association, there is a lot of work going into those data exchanges between the health insurance plans and the providers, and so it has been a lot of work and a lot of collaborative effort there. So I would like to circle back. We have a question from the audience, and Joanne, I think you touched on some of this question in your initial response. But what are some strategies to engage hospital healthcare systems to message and support Medicaid renewals? And I think that this last piece, particularly those with fewer Medicaid or uninsured patients, if it's not a big portion of their population.
Yeah, it's an interesting question, and I'm not sure what organization that's coming from, because from my perspective, we don't need a lot of strategies, because we've been talking to hospitals and health systems over the last couple of years about the unwinding through all of our members and all of the work groups that we have with our members. And they are interested in supporting. They are wanting the information. We have shared all of the information that's out on the DHS websites. We have tried to make sure that they know where they can get access to more information if they need it, how they can link with Covering Wisconsin, the Milwaukee Enrollment Network. They already know how to work with their health plans and Medicaid HMOs. So I think that they are very much engaged. Those with fewer Medicaid and uninsured patients, like I said, some of them are just picking up the phone and calling those patients directly. Or when they come into their hospital, they are making sure that they are that they have the tools and the resources they need to help those patients. So I don't know that there's much more of a strategy than if you wanted to work with one of your local hospitals or health systems. If you reach out to the patient assistance groups, if you can reach out to me and I can put you in touch with people, if you're looking for sort of one-on-one contacts, I'm happy to do that. And I think that you'll find great reception from hospitals and health systems across the state.
Thank you. And from the payer perspective, Kevin, I'm wondering if you have any thoughts on, from the plan perspective, where you can go to get more information, reach out to folks, things like that.
Yeah, I mean, I would say two things. Kind of what Joanna said, we know that a lot of providers and payers already have relationships, and most of those might be more on the contracting side or on the claim side. I would ask those people, if you're not getting feedback from one of the health plans, ask the people that you are working with. I know for most of the HMOs that I've been talking to, this is not like a small subset group within the health plan working on this. This is something that is being run across everything from call center folks to operations individuals to care managers. Everybody is at heightened alert that when they have a touch point with a member or with a patient, we're always trying to ask that next question. Hey, Mitch, we know that you're up for renewal in a couple of months. Do you have it on your calendar? Or you're up for renewal this month because there's something we can do. So if you're not getting that type of information, again, I think everybody is looking for intelligence. about what's going on, boots on the ground. So if you are a smaller provider and you're having some issues, I think if you've got, whether it be, again, not to take you up on Joanne's offer, but even if you were to call some of your HMOs and say, look, can we get rosters of your members that are coming to us? And in some cases, it might be as easy as like you said, I am finding, I would concur, sometimes the easiest tactics and the simplest tactics are the best tactics. It's most of the time it's in-person telephone call seems to be one of the best ways to change behavior. So again, for us, that's why call centers are so important, that we want to make sure every touch point with a member or with a patient that we're providing information, getting them to the right resources at the state level or at the income maintenance level as well. So again, we're all ready to help on the payer side as well as on the provider side. It's just raising your hand and saying, look, are we missing something? Are there resources that you can bring to bear? And you're going to find that people will clamor and say, yes, how can we get to yes on helping you get to your membership?
Kelsey, any additions there?
Yeah, I would just reiterate Kevin's point about health plans being very focused on taking advantage of every opportunity that they have in a member contact. So that can be universally anytime a Medicaid member is calling a health plan call center, regardless of their question. The question back is, are you aware that you have a Medicaid renewal? Are you reading your mail? And please be in touch with us for assistance in completing that renewal if that is in fact something that you need help with. Whether that's just as part of routine member mailings, regardless of what the mailing is, sticking in a flyer about the unwinding process and making sure that folks are aware of it through that mechanism. Whether it's when you call the call center, and you may be waiting for a few minutes to speak with a representative. You're getting messaging. Are you aware that the Medicaid redetermination process has resumed? Texts, emails, snail mail, you name it. Somebody in our membership is probably doing it, and are not wanting to leave any stone unturned. And folks are hungry for collaboration with others. And so again, I would just reiterate the point that if you raise your hand with a payer or with a provider, you're probably going to get some interest in seeking some kind of innovative ways to collaborate.
Great, thank you. So I would like to acknowledge that we have another question in the chat, and I'm actually not sure if attendees, if you can see these, so apologies if you can. We have a question from Lisa about whether or not CACs will be able to help patients remotely apply to Medicaid. And I think that is probably a question best directed to DHS. I don't know if we are the right group to answer that question. So, but appreciate you sending that in. I think we've been talking a lot about tactics in these recent responses, and I'd like to zoom out just for a second and kind of thinking broadly about redetermination. We're roughly 5 months in at this point. As you all have mentioned, this has been, we're 5 months into redeterminations happening, but this has been a multi-year endeavor. But just wondering from your perspectives, what is going well, what's working, what might need to be adjusted, and have your organizations had to make any significant adjustments to your strategies and processes since we've been going through this process? If we can start with you.
Is that me?
You clipped out when you said who. When you said who.
I'm so sorry, Kevin. Kevin, if we could start with you, that would be great.
I'm glad I wasn't the only one. I'm like, I don't know if I'm on deck now. I think let's start with, I think what's working well. And I think anecdotally, we hear that there are a lot of people calling, whether it be the income maintenance offices or Miles. I think you're seeing an immense amount, and we've talked about this, you're seeing an immense amount of collaboration where organizations are pulling together, we're sharing information, sharing best practices as well. I think that for those of us on the payer side that may have other plans in other states. I can tell you we share information on a daily basis of not only what works, but what not to do. And I say that knowing full well that you've seen one Medicaid program, you've seen one Medicaid program. But when it does relate to the redetermination process, there are some things that maybe we can learn from a different state or a different Medicaid program that maybe can get folded in moving forward, about maybe increasing capabilities, increasing the roles of providers and payers, what we can do. Again, you're going to see that common thread of we're all trying to maximize the touch point when we do have a member or a patient on the phone or online or in our care management platform. I do think we do have, I love the comment where we've got a lot of data, but sometimes, as Kelsey said, without the policy buffers around it, the data is just a spreadsheet that causes you to go, what am I looking at? I do think there's been a great acceleration of understanding the policy behind it, so that when data does flow through, particularly knowing when policy changes are happening in real time, trying to make sure that we're all on the same page of looking at the most recent information, so that yes, publicly there may be a little bit of a lag, but for many of us, we're getting real-time data, as we always have, right? But now we're getting augmented data files. How do we know what the state's thinking so that we can push that information out the door as quickly as possible? I think there's still always going to be opportunities, and I know that there are still, and we read the newspaper, you watch Kaiser, whatever it might be. We know that there's a lot of people that may not be engaging in the process. And I think that we're still in that position of just saying, okay, what can we fix? What can we adjust? Knowing that we want to incrementally improve. We don't want to necessarily make wholesale systems changes, because I think that anybody that's done any change management knows that it's a high risk. I'm not even going to say high reward sometimes. It's just high risk to do when you actually have people in the pipeline trying to get that information out there. But I think it really just, how do we continue to share best practices? Whether it be is a hospital engaging in a certain way, is the messaging resonating? I also want to make sure that we're really cognizant of the fact that we do know there's disparities in certain populations across the state. So how we communicate in Milwaukee might be different than how we communicate in Wausau. So how do we kind of get granular on all of that? The last thing I'll just say, though, too, is just a recognition of as we're having this conversation as a payer, a provider, a navigator, is always keeping the thought process and the priority process of the member and that family. And I think sometimes that's the biggest challenge that we have. I do joke with my internal team when we get frustrated about stuff. I ask them, how many times do you think about your open enrollment for your employer-sponsored health insurance? And if you didn't get the email come November, would you actually think about it? And I usually get a bunch of blank stares and say, and the reason for that comment is our members, patients, clients, they're living their lives. And so they're getting mail from us. They're getting text messages from us. They're getting emails from us. How many people the week before election shut down because there's just too much noise going out there? I think for us, it's really important to recognize that, so that we're being very strategic in how we communicate. And again, that's the benefit about us having forums like this, getting feedback. But just, I think there's been some great channels of communication that have opened up so that we're improving it. When we get done with redetermination, guess what happens on month 13? We start the process all over again. So we need to make sure that this is not a sprint. This is a marathon that will never end. And hopefully we can really build some of this best practices into what we do each and every day.
Thanks for that, Kevin. And I just want to quickly put another plug in. We have plenty of time for your questions, so please do submit those, and we will get those answered. Joanne, I'm wondering from the provider perspective, same question. Obviously, you've touched on a lot of the things. You've touched on a lot of this already, but are there any particular areas that you've been seeing that could be improved? We've touched on data a little bit. Obviously, we want timely access to data. That's a huge one. But yes, anything else that comes to mind, or trends that you've been hearing from your members on what could improve, what's going well?
Yeah, thanks. So I think that there's differences across the state, right? And so the area I hear the most about is obviously Milwaukee. And I think there have been a lot of challenges there with staffing and making sure that the pipeline is sort of open. But I also know that there's a lot of people working on that. One of our large members, was on a call just the other day on that very topic with, so you have providers and you have the plans and you have the state and you have the Milwaukee Enrollment Network and you have sort of all of these great people with great minds sort of on a call trying to figure out how can we fix this, right? How can we sort of get through this challenge, sort of most immediately so we can make sure people are getting, answers to their questions so they can get their applications done so the applications can get processed. So I think we all recognize that there are some challenges there. But again, I also know that there's a lot of people working on that and working to make sure that pipeline opens up as quickly as possible. But across the state, I mean, I think there are challenges, as Kevin mentioned, there are challenges with people sort of just either not hearing messages, getting inundated with messages. I know personally, like sometimes it takes people, it takes like 7 times for me to get something in the mail before I go, oh, I guess I better do something about this, right? So it does take, it's a concerted effort. It's are they getting the same message when they're going to calling their HMO versus when they're coming to their provider versus when they're looking on the state website versus, talking to their CAC. And I think we've all been working towards making sure those messages are very consistent, very timely, that we're sort of making sure that they're hearing those, as Kevin said, in a way that that is right for them, right? That they're, and that we're repeating those messages. So I think there are still challenges across the state in that regard. And all we can do is just continue to, as Kevin said, pivot as we need to, make sure we're all kind of on the same page, make sure we're all sort of giving those consistent messages so people know what they need to do when they need to do it, and they can complete those applications.
Yeah, Joanne, you mentioned the communication. Kevin mentioned it too. Kelsey, I'm wondering whether you've been hearing from your members any feedback generally on kind of how well informed the population is. I understand this is not going to be a very scientific gauge, but generally, how have people been responding to the messaging? Is there a lot of confusion in the calls that your members are getting? What are you hearing?
Yeah, so first, I guess I would offer a bright spot, which is that for DHS communications, the individualized communications that the department is sending to enrollees, and then for health plan communications that are also individualized to the enrollees, I think the returned mail rate, if you're sending a text or an email, the bounce rate has been lower than you might think it would be, especially for a Medicaid population that typically is harder to reach than other lines of business. So that's the bright spot that I would offer. That seems like, at least from an individualized communication standpoint, the contact information I think has been a pleasant surprise for folks, and it being more up to date than we thought it might be. And there generally still does seem to be a general gap in understanding. And I think that's why you're hearing from Kevin, from Joanne, from me, about the kind of multitude of different touch points that providers and health plans are trying to take advantage of, most especially when they have a purposeful engagement point with their health plan or their provider. It's one thing to receive a text or an email or a letter in the mail on a Wednesday when you have a million other things going on, and you think, well, I'll open that later. But if you're in the provider's office, if you are calling your health plan because you have some other question related to your care or to your coverage, that question of, do you know that this is a process that is happening? And do you know what steps that you need to take in order to make sure that you can make it through this process so that you don't have either a loss of coverage that you shouldn't have, or a gap in coverage as you transition to something else? So, I think what we're hearing is there's still an opportunity to educate folks, to make sure that folks are aware. And I'll get even more specific. It's sort of two parts. One is, are you aware that this process has restarted? And are you aware of the actions that you need to take? Because both of those pieces are, I think, incredibly important, and they are, in fact, actually different. For the department, their emphasis, very rightly, has been on right person, right communication, right time, generalized messaging that issues a call to action when it is not timely for that person is not something that we want to do. We want folks to be aware that at some point they will be asked to move through this process, but we don't want them taking steps out of order. That's not good for them. That's not good for the Medicaid program overall. It's not good for the income maintenance agencies who are trying to manage call volume and processing time. And so that piece of, do you know what's required of you? And that's especially important for some of our most vulnerable populations. Think about folks in our SSI program, in our Medicaid long-term care programs. In some cases, it's not just the enrollee who is involved in that renewal process. You could say this is true for kids as well, who have a parent involved. Sometimes it's a legal guardian, or it's some other kind of provider that needs to be involved in that renewal process. And so, the generalized messaging about the process of redeterminations restarting is important. And then the specific call to action that's tailored to the specific individual circumstances and meets them at a point where they're ready to engage has been a really important piece.
I'm really glad you brought up kind of that point of care opportunity for a touch base too. I think that's something that with our FQHCs we've been talking about a lot is, how do we use this data that we're getting from our health plan partners to incorporate it into those like in-office workflows and make sure that we can start connecting people when we have them, in the room to the resources that they need. And it is a challenge, but it is, it's a great opportunity to kind of snag people and make sure that they're going through the process and understand what they need to know. So going back, I think Kevin, both you and Joanne started talking a little bit about social drivers of health and maybe some groups that we expect might be disproportionately impacted by this process. And really question for the group as a whole of whether you've been in the early months seeing that play out, whether there are any noticeable trends or whether it's kind of too early to tell. And I don't know if we have any volunteers to go first, or I can pick on Kevin again.
Oh, I love the dichotomy there. Do we have any volunteers, or everybody else step back? I'm going to take the approach to say I think it's really too early to tell. And I say that for just kind of two different reasons. First of all, I think it's, again, the policy, as Kelsey said, the policy has shifted a little bit here since when we first went live with that first group of kind of the interchange only group, right? Like the people that they had to manually go through the process. And so I think that as the policy has changed, and as we know that people have had extensions that have been on, and just knowing that there's windows after disenrollment that are still available for people to move back in, we're still kind of in that initial window, to be honest with you. I think we're getting close to being able to have some really actionable knowledge of what happened in May and June, right? So, we talk about in the insurance business, you talk about claims lag, and that tends to be, there's a problem there. This is the same thing. There's an enrollment lag that I think is important. I do think the other part about it too, and this is not about redetermination, but I think this is the other challenge, is that the ability to have actionable, granular data around groups, and I'm thinking specifically about individuals and groups that might be disproportionately hit with inequities, whether it be eligibility or just healthcare in general. That's still an emerging data field, if you will. I'm thinking about the data that we get from the state. I know a lot of health plans do a lot to augment that. I know health systems do a lot to augment that as well. So I do think that that's the other part that I would say that we know globally that we could probably identify zip codes which I think historically, I think we all would know that those are the same zip codes that not only our FQHC partners work with, but they tend to also be areas where we know that there's food deserts. We know that there's transportation issues, education issues. So I think we will know at a higher level. And I don't know if there's going to be, I hope that we have a lot of aha and surprising moments where all of a sudden we realize that the disproportionate is we've got more people engaged in that part in those particular communities. But I think as I think about the future, I think this is what are the lessons learned from redetermination on what the next round, a year from now, or if we have the same conversation, what data fields are going to be now standard so that when we look at enrollment, when we look at eligibility, we're looking at race and ethnicity and SOGI ubiquitously in through that lens, because that's going to make us better providers. It's going to make us better health plans. It's going to make us better community-based organizations. It's going to enhance relationships. And then as Joanne said, which it really gets back to the individual. If they see themselves in that communication, they're going to take action, not just on redetermination, but PCP visits, immunizations, vaccines, all of these other issues that I think we're talking about redetermination now, but there's a bigger systemic issue when we talk about disparities that this is just yet another thing that I think when we get it to October, November, we're going to say, okay, we know this population, we need to lean in stronger in this community. What does that look like? And I'll be a little bit provocative. It's not going to be a health plan, and it'll be probably more a provider, but it's going to be community-based organizations. It's going to be the people on this call. It's going to be faith-based communities. It's going to be a lot of those people that are engaging with those families on a day in and day out basis. How do we make sure that they understand and that they can help communicate that message as well? And that's going to be better for all of us moving forward.
Joanne, Kelsey, any additions to that?
Well, I guess what I would add just very briefly, and then Joanne, I'll kick it to you. But I think what you heard out of Kevin's comments was too early to tell, and not just in this space, but in all spaces within the Medicaid program and in others. Health plans have an eye towards disparities, and so this is something that we follow very closely and have an eye towards all the time. And so this is not something that just because it's too early to tell doesn't mean that we're not already looking for it and trying to head anything off that might be emerging, even if we don't quite have a clear picture yet.
Yeah, I liked Kevin's point about sort of zip code level data. As you can tell, I'm a data geek. So data, but zip code level data, I think really does help us and helps us get to sort of where are those communities, where are those areas where we might be having gaps, where we need to put more resources, where we need to sort of double down on our efforts. I think there are some organizations, I'm sure covering Wisconsin, I'm sure the Milwaukee Enrollment Network are already trying to look at that kind of data and target their efforts. But I think, as Kevin said, come November, December, we'll have a better picture on that.
So we do have a couple of questions that have come in, and Kevin, you made the point about kind of these activities that we're engaging in right now in redetermination. They do apply down the road too. And the question that came in was, do you think that health plans or hospitals will continue any of the outreach they've started doing during unwinding after that concludes? Will there be support for continuing that capacity and priority? So wondering if any of you have thoughts on that.
I'll jump.
You go ahead, John. No, you.
I was just going to say, I'll jump in from the hospital perspective, and I would say, yes, I do think hospitals will continue the work that they're doing. They have always done this work. There have always been financial assisters, patient assisters, always helping folks who come into the hospital who are uninsured, who don't have coverage, to see what they might be eligible for and help them sign up for coverage. We have, since the ACA and since the ACA allowed for more comprehensive presumptive eligibility determination in hospitals, which means that if patients come into the hospital say they're in an inpatient setting and they have, or in the ED and they don't have coverage, hospitals can work with them to see if they might be presumptively eligible for Medicaid, get them signed up. Coverage starts right away until the full eligibility determination is complete. And we've been engaging in that work, for a very, very long time. So I don't see that changing. I will add that presumptive eligibility is not where we want to be, though, right? We would prefer that people get signed up for coverage before they come in for services. But that's always been kind of a fallback for us. So yes, hospitals, this is part of their mission. This is part of what they do every day. And so I see that they will continue to do that.
And Kevin, if I could, because I know you're going to jump in, and if I could add a little bit before you do jump in, wondering from your perspective and yours, Kelsey, whether some of that outreach that you were doing pre-pandemic on things like flu vaccines and breast cancer screens and stuff, whether you've had to shift priorities and shift capacity over, due to Medicaid unwinding. So I'll just add that little piece in.
You want me to go, or you want to
Go
take
ahead,
first?
Kevin. Sorry, that's my fault.
No.
Yes, please, Kevin.
I was
go
actually
ahead.
looking at Kelsey, seeing if so this is an amazing question. And I think it highlights kind of a little bit of a difference between the payer and provider community, because the provider community, yes, has for a long time had a lot different ability to engage at the local level and at an individual level with a patient when they come in, presumptive eligibility probably being one of the biggest tools. But then just knowing that they can manage that individual back from presumptive into full, because there's a vested interest of her coverage there that happens. I think that as we move forward, I think this is one of the questions that Medicaid managed care plans would like to have this discussion, because what we've been looking at is other states are much more open in terms of the role that Medicaid managed care plans can do. Again, it's never a steerage issue. There are certain defined boundaries that thou shalt not cross. But what you've heard from us today, all of us, is we're trying to maximize every single member or patient touch point. And unfortunately, we still have a system where if I've got somebody that's on my advocate team or a call center team, we can only get them so far before we have to either do a warm handoff, or in many cases, we have to detach and allow them to move into the eligibility pipeline. I think there's an opportunity to have a better discussion about that, because I think, if we've got somebody who's motivated, who wants to get into the system, how can we help them through, especially if they're already one of our members, so that they're getting all that information, but we're helping them through that. Now, that's a bigger discussion. That's something that we can't talk about right now because we're in the throes of actual redetermination. But there's a lot of little things like that, I think, that are incredibly important that could evolve out of, it's one of those things where nobody wants to say something good that comes out of COVID. But how do we learn from it in the best way so that we are actually improving the system at large with the member fully in mind? The second thing, I'll say this, Mitch, for us, it's not an either or. We don't have the luxury of putting our dollars and our resources as health plans into redetermination and then not looking at it's flu season, it's COVID variant, ... It's RFVS. We are running both. And I think that's where, just like the hospitals and the amazing work that all of those frontline staff do and everybody that the hospital systems do, our teams are also doing double, triple duty as well. We're still meeting our quality measures. We're still doing our outreach per our contract. We're still troubleshooting on a day in and day out basis. There's always going to be that one challenging member case where you're, where it's what we do. They're navigating through the system, and we have to go one step further than what we need to. And we still have all of our membership that's going through redetermination. So I would say it's not back down. If anything, we're trying to find ways of leveraging our population health approaches, our disparity approaches, to say, yes, don't forget this, or we've got you contacted. Can you also make sure that you're going to the inconvenience? So the answer is no, we're not. There's no diversion of resources. It's added more work for every part of the health system.
Kelsey, any burning thoughts, additions to to this discussion.
Well, very well said by both of my colleagues here. And I think I would just go back to one of the earliest points that I made, which is that this has not been a process that's been about restarting what we were doing before. It's required kind of a soup to nuts evaluation of the process and how enrollees experience it. And once you've done that, I'm not quite sure why you would go through that process of trying to make everything that you're doing better at every step of the way, and then decide that you were going to revert back to what you were doing before.
So doing a quick time check here, we've got about 10 minutes left, and we do have one more poll for everyone. So I think that will be pulled up in a second here. And so while that's getting set up, I just want to take a moment and thank all of you preemptively. This has been a fantastic discussion so far, and I can't believe we've only got 10 minutes left. I feel like we could be going all day. After the poll, we spent a lot of time on redetermination, and so I want to make sure we sneak in a couple other questions that have a broader view on health insurance coverage, but we do have a couple of last questions from the audience to get to before that. So were we able to see the poll? There we go. So are you observing more consumers choosing short-term limited duration plans? It looks like we've got the majority saying no or not sure. So while that poll plays out, I wanted to go back to a question from the audience. So Julia was asking, could someone share how pharmacy networks are sharing information with people at point of service or other messaging platforms? Does anyone feel that they could take that question on, have enough knowledge about how the pharmacy activities are playing out and how they fit into this process?
Well, Mitch, let me prime this why you're kind of getting the stuttering response here. Pharmacy as a benefit is carved out of Medicaid HMOs. So for all 14 Wisconsin-based Medicaid HMOs, we actually don't administer that benefit. It's actually on a fee-for-service basis for all Medicaid members. So this has actually been, and I'll kind of encompass a lot of other providers. And you heard a little bit, Joanne, I know that you're getting fee-for-service feeds from the state as well. I know that this has been a pretty good conversation of like, who else do we need to talk to? Not only in the collectively, not health plans, but we as anybody involved here. Because I think in the Medicaid space, you not only have pharmacists, you also have non-emergency medical transportation as a carved out benefit. And obviously it's a very captive, somebody that's actually going to a ride. Can we also provide additional? And I do know that there are efforts underway to really maximize each one of those touch points. I just don't know the specifics of what those comp plans are. I didn't want people to think that it's a stump question because it's not an area that, at least on the health plan side, that we have a direct line of sight to. And it's probably, Joanna, it's probably a hit and miss even within your members as well. So.
Yep, completely. And that is also why I kind of left that one out for the room to see who wanted to take it on. I can say from the FQHC perspective and with my WIPCA hat on, we have had discussions with independent pharmacy groups on kind of, how can we work together to get folks not just engaged in primary care, but, meeting all of those performance measures that you mentioned, Kevin, earlier on, and also get out the redetermination messaging too. I think it is challenging because there's not necessarily as you mentioned, Kevin, pharmacies carved out of Medicaid, so there's not that direct kind of business relationship that you necessarily that you do have when you're talking about, say, hospitals to HMOs to DHS. There's those clear lines are not necessarily there. So, but it's definitely an area of opportunity, I guess, because that is a group of that is a group of providers that is engaging very frequently with patients. So just being cognizant of time, we've only got about 5 minutes left. And so I wanted to end this session with a question that's not about unwinding. And so in a couple minutes, if we could start with Kelsey and just go around the group, outside of unwinding, what are your top priorities, concerns when it comes to health insurance coverage in the state? So Kelsey, yeah, if we could start with you.
Yeah, it's a great question. And I've been reflecting on this for a few reasons as of late. I think there was a moment where we all thought we were going to reach a quote unquote new normal after the pandemic. And I think we have all come to find that there is no business as usual. And we're not in business as usual yet, even if there were one. When it comes to Medicaid specifically, for our members, as they look at that line of business, there's very much still a continued rebound of certain kinds of care within the Medicaid population that's trailing behind other lines of business. That includes preventive care. There's work to do there. There's some big proposed rules from CMS related to both fee-for-service and managed care in the Medicaid program that are likely to be finalized later this year. So even outside of the unwinding process in Medicaid, there's still a lot going on. In the individual market, we're really lucky, I think, that we've got such a competitive and strong individual market here in Wisconsin. I mentioned earlier, our members largely offer coverage in both Medicaid and the individual market, so they can offer continuity for folks for whom that's appropriate and needed. And then I saw a couple weeks ago some really interesting research coming out of the Employee Benefits Research Institute. I was looking at some data over the last 10 years and somewhat of a reversal of a migration among large employers from self-funded products to more fully insured products, which had been kind of that's the opposite way of where it was trending for a long time. And then in the small and medium-sized groups, starting to trend more towards self-funded products and away from fully insured products. So I say all that, I guess, to say there is no business as usual. There's lots going on in the Medicaid space related to the unwinding and outside of the unwinding. And as we think about comprehensive coverage that's accessible and affordable to folks across the state, there's also a lot of other things to consider and many new emerging trends that we're trying to stay abreast of.
Joanne, I wonder if we could go to you next.
Sure. So it is a great question. And there is a lot around health insurance in particular that our members are working on coming out of COVID. As Kelsey said, there's not a new normal. I heard a presentation a few weeks ago that for hospitals and health systems, it could take 4 to 6 years still to kind of stabilize. And it's sort of eye-popping when you think about that, right? So I think we're all doing our best to kind of work with where we're at with workforce challenges in healthcare, whether that's in hospitals and health systems. I believe health plans have some workforce challenges, and just across the state, all employers are having some workforce challenges. So that's really kind of one of the things that's really top of mind for our members. But when it comes to sort of health insurance, we're pleased that through the individual market, the ACA exchange, that there are the enhanced subsidies have continued and are continuing through 2025 because we know that helps with consumers accessing comprehensive, affordable coverage with low deductibles, low co-insurance, so that they can make sure they can access services. Behavioral health continues to be a challenge, I think, for all of us, and that is something that's also top of mind for our members. But as we're moving forward, again, I think that we in Wisconsin have a great collaborations, great commitment to this work. And I think that we are all sort of doing our best to make sure that we keep and maintain that low uninsured rate in our state that we've had. And so I think that that, again, gives me hope in our state.
Kevin, any final comments?
I'll end with this. Kelsey and Joanne, they hit everything. Coverage is obviously critically important, and it's the great work that you all do. I think if I look at the next 5 to 10 year horizon, I think we also need to, and Mitch, you brought this up. It's about, are we improving health? Sometimes in these discussions, we kind of get lost in coverage and benefits and things like that. But are we modernizing what healthcare looks like, both from a payer side as well as a provider side? Are we recognizing the role that social determinants have in actual positive health outcomes? Are the tools there in Medicaid, in the exchange, and Medicare for dual SNPs, for commercially insured? Are we working towards the same goals, whether it be provider, payer, community-based organizations? I think there's some really great stuff that because of the new normal, if that we want to call it that, between the different parts of the healthcare system, it's about quality and it's about improving population health for all of us. So I'm bullish in the future. I think it's going to be a great opportunity. We've got some challenges, and hopefully everybody knows that we're all hands on deck, and we're going to do this. Old boss of mine, and many of you know, used to say we're all in this together, and it's very true. There's not one of us that's not. So I just appreciate the opportunity to share, and I think you all heard the doors are always open for all of us if anybody has any other questions on what we can do to help you all.
So with that, we are out of time, and I just want to thank you all again for your time today. Attendees, thank you all for listening in. It was a great discussion. So really glad we could do this. Allison, I'm not sure if you have.
Yeah. Thank you so much. This was really excellent. I loved hearing all that you were sharing. Thank you, Mitch, again, for moderating. Fantastic conversation. I so appreciate all of your time. And attendees, that's all we have for today. Thank you for attending and your questions. We'll reconvene again tomorrow morning. You use the same link you had today. Come back into the platform and the new sessions will pop up. And just as a reminder, we do have those virtual exhibit booths. There will be some sponsors who will be representing there and can share information or answer questions. So thank you again, and we'll see you tomorrow. Bye.